Hello everyone, I'm Dr. Ala Musbah, Professor of Obstetrics and Gynecology, Faculty of Medicine, Mansoura University. The topic of my lecture today about hysteroscopy. So what we wanted to discuss today, the definition, indication and contraindication for hysteroscopy, the equipment, distension media used, preparation and the technique for hysteroscopy, complications, advantage. Let us start with the definition. Hysteroscope is an endoluminal endoscope that can be used to visualize cervical canal and uterine cavity and to perform a variety of intrauterine procedures. Let us see this picture. This is the hysteroscope and this is the uterine cavity in this picture and in this picture. So the aim of hysteroscope is to visualize the uterine cavity. And this is one of the gold standard or considered the gold standard for diagnosis of intracavitary lesion, like polyp, like septum, as in this picture, uterine septum, or polyp, or fibroid, or adhesions. So the aim of hysteroscope is to visualize the uterine cavity and diagnose any intracavitary lesion. So hysteroscopy involves inserting rigid or flexible hysteroscope through the cervical canal into the uterus and then using distending media to allow for complete visualization of the uterine cavity. So I need a media to distend the uterine cavity to allow the visualization of the cavity and to diagnose any pathology. This media may be CO2 or liquid like high viscosity liquid like Dextran 70 or low viscosity liquids like glycerin 1.5%. So this is the media which distend the uterine cavity to allow visualization. And this is a picture the hysteroscope inside and visualizing the uterine cavity. Okay, sorry. What is the indication for hysteroscopy? Any suspicion of intracavitary lesion like endometrial polyp, like submucous myoma, like intrauterine adhesions, cases with abnormal uterine bleeding, hysteroscopy can be a diagnostic and also can take a biopsy from suspicious area of the endometrium for histopathological evaluation and also can be therapeutic in cases of abnormal bleeding. If malignancy is excluded, I can do resection for endometrium as a treatment for abnormal uterine bleeding and as an alternative for hysterectomy. Also can be used in cases with abnormal endometrial thickening and thickening biopsy, in cases of postmenopausal bleeding, in cases with infertility to diagnose any intracavitary lesion, and also in cases of recurrent miscarriage to diagnose intracavitary lesion and abnormalities in the endometrium. Also can be used in cases with suspected Mullerian congenital anomaly as uterine malformation, as uterine septum, and so on, septate uterus. Also can be used to remove a foreign body or embedded IUD retained inside the uterus for extraction of the IUD. So what is the contraindication to do hysteroscopy? Any acute pelvic infection, any current vaginitis, cervicitis, or endometritis, or presence of genital herpes, any recent uterine perforation, if there is cervical or endometrial cancer, if there is moderate vaginal bleeding, can be considered a relative contraindication to hysteroscopy because may obscure the vision to see the pathology because of the excess bleeding. Pregnancy is also a contraindication to hysteroscopy unless It is used in the setting of retained IUD. You want to remove the IUD in the early pregnancy to maintain pregnancy. Okay. Also, in cases with retained product of conception and we want to remove it, we can use hysteroscopy. So, what is the equipment of hysteroscope? This is the set of hysteroscopy, as you see. This is the telescope, or hysteroscope, and sheath, and this is for irrigation, fluid irrigation, and this is for the light source, and this is the lens is here, and here is the eyepiece connected to camera. This camera connected to monitor. So I see the cavity of the uterus as in this picture and this monitor. Okay, and this is the light source fixed to the telescope to allow illumination of the cavity, and the picture of the cavity can be seen on the monitor by the gynecologist and his assistant. Okay, so what about telescope? What it is formed of? It is formed of eyepiece. This part is called the eyepiece. This part is called the barrel, and this part, the end, is called the lens. The lens may be flat one, as in this picture, or zero, or angled one. And the angled one range between 0 up to 70. And the most common in use is the angled 30. Okay? There is advantage for each one. Flat one or 0 can let you see the panoramic view. Okay? And you can see the instrument inside the uterine cavity distant. Okay? This is the flat one. Also, you can see post-tubal ostia because you have a panoramic view. While the angled one let you see certain angle or certain side, like in this picture. This is the angled one. You can see the tubal ostia on the other side here, but not this side in this position. While the 0 1 or flat one, you can see panoramic view as you see in this picture. This is the difference between 0 or flat and the angled one. And we have different degree of angle, as I said, 12, 15, 25, 30, and 70 degree. What is of common is 30 degree in angled one. Okay. What else? In the equipment, the light source. As in this picture, this is the light source. We have 3 general types of light generators: tungsten, metal halide, and xenon. The best is the xenon. Xenon generator provides white light, which gives a superior color and intensity. Okay. Then in the equipment also diagnostic sheaths. As you see in this picture, this is the single channel diagnostic sheath, and this is double channel diagnostic sheath. Diagnostic sheath is used to deliver the distension media, and it is fed by means of watertight seal lock. It is about 4 to 5 millimeter in diameter, with 1 millimeter clearance between the inner wall and the telescope, through which the distension media is transmitted. So in this picture, you can see the sheath, the telescope, okay, and this is the flow, the irrigation media coming from here, and this is the outflow from here, and this is the light source, okay, connected. Okay, as you see in the operative hysteroscopy, is performed with digital camera attached to the eyepiece of the telescope. The operator and the assistant all view the field by way of high resolution video monitor. As you see, this is a video monitor in front of the doctor. Okay, this is the table of hysteroscope. It should be flat, never to make the patient lie in Trendelenburg. It is contraindicated. The table should be flat. Okay, and this is the monitor, and this is the set for the light source, the video recorder, and the camera base. Okay, and this is the table with hysteroscope and sheath and the camera head. What about operative sheath? Operative sheath is larger in diameter, about 7 millimeter, equipped with two channels, one for distension media and the other for introduction of ancillary instruments. What are the instruments may be used with hysteroscopy? Like biopsy forceps, grasping forceps, scissors, morcellator, monopolar and bipolar electrodes. Okay, as in this picture. What about resectoscope? Resectoscope, as in this picture, specialized electrosurgical endoscope, consists of inner and outer sheath equipped with 30-degree telescope. As I mentioned, the lens is 30 degrees is commonly used. The inner sheath has a common channel for telescope, fluid medium, and the electrode, while the outer sheath is for fluid return. The operating tools consists of 4 basic electrodes. Look to this picture to see the 4 basic electrodes for resectoscope. The cutting loop is this one. The ball, this one. Okay. The button and the angulated needle. And this is the bar, and this is the angulated needle. Okay. So this is the ball, this is the bar, this is the angulated needle, this is the cutting loop. As you see in this picture, this is the cutting loop and this is the resectoscope with 2 sheaths, inner and the outer one, and 30-degree lens. Okay, so we have several types of hysteroscopes with different sizes also available for diagnostic and the operative purposes. And we have 2 main hysteroscopes, flexible one and the rigid one. Hysteroscopes are available at viewing angles ranging from 0 to 70, as we mentioned before. They all easily connect to fluid channels, light source, and the video monitoring system. Continuous flow of descending media is needed for optimal visualization of the endometrial cavity. Most hysteroscopes have an operative channel that permits the passage of surgical instruments such as a small hysteroscopic grasper, scissor, or tenaculum. This is the rigid hysteroscope, as you see in the picture, used in patient and in complex operating room procedures, 3 to 5 millimeter in diameter, more durable and provides superior image. This is the flexible hysteroscope, as you see in this picture, used in office hysteroscopy, characterized by flexibility, tip deflection of 120 to 160 degree, can be used with irregular shaped uterus and make navigation around the intrauterine lesion. This is advantage for flexible one. This is an example for flexible hysteroscope. The Olympus flexible hysteroscope has outer tip with a wide 100-degree tip angulation range, and that the operator may adjust. It is about 3.1 millimeter in diameter. It features a wide field of view and an instrument channel, as you see here. Okay, this is the flexible hysteroscope. What about types of distension media? We can use carbon dioxide, we can use high viscosity fluids like dextran 70, we can use low viscosity fluids with electrolytes like normal saline and lactated ringer, or low viscosity without electrolytes like glycine 1.5%. So what is the difference between this media and what is the indication for its use? In carbon dioxide, I can use it only in office hysteroscopy for diagnostic purposes. I cannot use it completely in operative hysteroscopy. So it is used only for diagnostic purposes in office hysteroscopy. The disadvantage of carbon dioxide is the occurrence of gas embolism, and also there is no effective way to remove blood and debris if present. Okay? But it is used only, as I said before, for office hysteroscopy. Also, it can allow evaluation of endocervical canal. This is the carbon dioxide medium. Okay? What about the high viscosity dextran 70, low viscosity fluid with electrolytes like, as I said, lactated ringer, normal saline 0.9%, easily available, of course, and of low cost, but the disadvantage, visibility is lost with bleeding and risk of complication like pulmonary and cerebral edema. Also, I can't use saline because of the electrolytes in case of I using electro surgery with monopolar. Okay, it's very risky to use normal saline with monopolar electrocautery, but may be used with bipolar one. Okay, the best is the use of low viscosity fluid without electrolytes in operative hysteroscopy, like glycine 1.5%, and it is the most commonly used where electrosurgery is used. Okay, so can be used either you are using unipolar or bipolar. Glycine 1.5 can be used. So fluid distension media, as this example, this is 1.5 glycine and this is saline 0.9%. Fluid distension media allow the irrigation of the cavity for better visualization with operative hysteroscopy, and the electrical current loops used for dissection fluid medium must be carefully chosen, as I mentioned before. If I'm using monopolar, I'm going to use glycine for sure, not normal saline, if I'm using monopolar electrocautery. So, fluid containing electrolytes must not be utilized with monopolar current due to the risk of energy dispersal to the surrounding tissue. But when bipolar instruments are used, electrolyte-rich fluid descending media such as normal saline may be selected. Okay? Muscle of the uterine wall require a minimum pressure of 40 mmHg to be descended. What about the instruments used with hysteroscopy? I want a cascus speculum to be inserted inside the vagina to expose the portion of the cervix. I need tenaculum or valcellum, single tooth valcellum or tenaculum, cervical tenaculum, or also I need uterine sound and Higger's dilators. This is the Higger dilators. I need also ring forceps. All of these instruments should be ready on the table before doing hysteroscopy. But you should know that if I'm doing the non-touch technique or vaginoscopy, I'm not in need for these instruments because I'm only using the telescope, just the telescope. Okay? This is for vaginoscopy or non-touch technique. I'm not using this instrument. But the traditional technique of hysteroscopy, I'm using all these instruments. Okay? Okay. What about anesthesia? I have either local paracervical block, as in this picture, or epidural block, as here, or general anesthesia. Okay. What about paracervical block? Look to this picture, please. I'm going to insert lidocaine 5 millimeter, 1 to 2%, plus or without norepinephrine to prolong its action, or to prolong the action of anesthesia. Some prefer to add norepinephrine, diluted one, but if it is risky, it is better to be avoided, okay? Especially if the procedure will take short time. So, lidocaine 1 to 2%, 5 milli is injected at 4 and 8 o'clock. At 4 and 8 o'clock, okay? Where is the site? The site is the vaginal fornix, or the reflection of the vagina of the cervix. At the site of reflection of the vagina of the cervix at 4 and 8 o'clock. For depths, you inject the needle for depths of 10 millimeter. Then you inject 5 millimeter of lidocaine, 1% in each side. It's quite enough. Some prefer to do the 4 puncture technique, not just the 4 and the 8 o'clock, but also another injection in 2 and 9 o'clock. Okay, so but we think that 4 and 8 o'clock is quite enough to do paracervical block. Okay, if you want a longer time and the operative procedure will take longer time, you can use epidural anesthesia, so long as there is no contraindication. If there is any contraindication for epidural and you need longer time operation, you can use general anesthesia. So you can choose between the paracervical block or epidural anesthesia or general anesthesia. Okay, what about the preparation for the hysteroscopy? Which is the best time? Proliferative phase or secretory phase? Proliferative phase is the best in menstruating woman in premenopausal age. But in postmenopause, you can do it, of course, at any time. Okay? Why I'm using in premenopause the proliferative phase, not secretory, to avoid the secretory effect in making the polyps, making the endometrial polyps, since the endometrium may have the picture of polypoid nature, so may make you misdiagnose the case. Okay, so during secretory phase of the menstrual cycle may lead to overdiagnosis of endometrial polyps, since the endometrium may appear polypoid during this time. Okay, we will ask the patient to have a misoprostol vaginal tablet before surgery by 4 hours or at night before operation. Some prefer to do that to help for cervical dilatation, make it easy during hysteroscopy, but it is not routinely done. Then you should take consent, informed consent, and you should discuss with the patient the risks and benefits and alternatives for hysteroscopy before doing the procedure. Prophylactic antibiotic is not routinely given except in certain cases, so you can do hysteroscopy, this minimal invasive procedure, without giving prophylactic antibiotic. If there is a risk of infection, you can give antibiotic. Of course, you should take complete history from the patient and do physical examination, general abdominal and local pelvic examination, and you should do pre-operative pregnancy test to be sure that the patient is not pregnant, so long that the patient in the childbearing age. Okay, what about analgesia? You can, in office hysteroscopy, you can give the patient 800 milligram of ibuprofen 2 hours before doing the procedure to minimize the pain after and during the procedure. Okay? What about the technique of hysteroscopy? The patient is positioned in dorsal lithotomy position. Avoid Trendelenburg position. Remember that. The table should be flat. Do bimanual examination as routinely to feel the uterus, the nexi, and so for any abnormalities. You can evacuate the bladder using metal caster. Fullis caster is not needed. Then the hysteroscopy is set up. You see in the picture. The camera is white balanced and focused, and the inflow tract is primed. With vaginoscope entry technique, I'm not need for any instruments like casca speculum or cervical tenaculum or dilators because I use only in vaginoscope the telescope, just as the telescope. But in traditional hysteroscopy, I use this. So this is the difference between vaginoscopy, the no-touch entry technique, and the traditional technique. For vaginoscopy, introduce the hysteroscope into the vagina. I said without inserting the casco speculum, just the telescope inside the vagina. The vagina is then distended by the irrigation of the media, fluid media, and or gas like CO2. And the cervix and external os located. Also, the posterior fornix is identified. When you reach the external os, the hysteroscope is carefully inserted and passed through the internal os into the uterine cavity. This is called vaginoscopy or no-touch entry technique. What about the traditional technique? You insert a speculum, casca speculum, open the plate, exposure of the portion of the cervix, then the anterior lip of the cervix is grasped with single tooth tenaculum. The cervix is then dilated with Higger dilator until reaching the size admitting the hysteroscope. Then admit or insert the hysteroscope through the cervical canal till reaching the uterine cavity. And while you are holding the cervix, the anterior lobe of the cervix with cervical tenaculum to straighten the uterus and facilitate the insertion of hysteroscope inside the cavity. Okay? Now you are inside the uterine cavity. Once inside the uterus, the entire uterine cavity should be inspected. And any pathology, like in this picture, the polyp here, can quickly be identified and the plan made for the operation needed. For example, for this polyp, I can do loop excision for this polyp or cutting by scissor through the pedicle. Okay? Also, the bilateral tubal ostia on both sides, tubal ostia here and here, should be identified. Further techniques varies depending on the type of intrauterine pathology. You may find intrauterine adhesion, so you do adhesolysis. You may find submucous myoma, so you do hysteroscopic resection of this myoma. Okay, so it depends on the intracavitary pathology. In this picture, there is polyp, and this is polypectomy using either monopolar or bipolar electrocautery or with operative microscissor. This is also polyp. This is the intrauterine polyp. This picture shows you the submucous myoma with hysteroscopic resection of the myoma in this picture using the loop. Okay, as you see, resectoscope, cutting part of the myoma till you finish the myoma. Okay, so myomectomy is accessible by the operative hysteroscopy, and you can divide the myoma into which can be dealt with hysteroscopy, the three types: 0, 1, 0, 1, and 2. You remember the Figo classification of leiomyoma? So the Figo classification type 0, 1, and 2. Type 0, which is intrauterine with pedicle. Completely, the myoma completely intrauterine with pedicle. Type 1, there is submucous myoma more than 50% inside the uterine cavity. Type 2, there is submucous myoma but less than 50% inside the uterine cavity. These three types may be indicated for hysteroscopic management. Okay? But type 0 usually finished in one session and resected easily by resectoscope, okay, in one set. While type 1 and the type 2 may need 2 sessions. I remove as much as I can from the myoma with resectoscope, then give certain time, then do another operation with hysteroscopy to complete the removal of the myoma, because the remaining intramural part will bulge inside the cavity, so I can remove it completely. Rarely to finish especially the type 2 in one session. It's so difficult to finish the whole myoma resection in one session. So it needs 2 sessions. Also, hysteroscope can be used for septoplasty, removal of uterine septum. This is septate uterus and this is the septum. We can cut this with the hook hysteroscopy, okay, perpendicular in the septum, or with cutting with scissor. Okay, this is intrauterine adhesion. It's called Asherman syndrome. With using hysteroscopy, I can do adhesolysis, cutting the adhesions. Also, I can use hysteroscopy to remove retained or embedded IUD, as in this picture. This is the IUD. Also, in this picture, this is IUD retained inside the uterus and embedded. I can remove it by hysteroscopy. Also, through hysteroscopy, I can do endometrial resection in cases with abnormal uterine bleeding after exclusion of malignancy. Like in this picture, this is endometrial resection using resectoscope, as you see in this picture. So what are the complications of hysteroscopy? Maybe intraoperative or postoperative bleeding. Postoperative bleeding may occur due to endometrial slough, spontaneous expulsion of intramural portion of previously resected submucous myoma, or endometritis. Also, complication may happen, like in this picture, perforation of the uterus, which may cause bleeding also. Complication related to distension media due to CO2 insufflation may cause cardiac arrhythmia or embolism, or due to fluid may cause anaphylactic reaction, fluid overload, and hyponatremia, which cause cerebral edema. Also may cause pulmonary edema or adult respiratory distress syndrome. Late complication like infection, PID, vaginal discharge, and adhesion formation. Lastly, what is the advantage of hysteroscopy? Of course, hysteroscopy is minimal invasive procedure, have a shorter recovery time, shorter hospital stay, less pain, medication needed for after surgery. Of course, avoidance of hysterectomy and can be used as an alternative to hysterectomy, as in case of hysteroscopic resection of endometrium. Possible avoidance of an open abdominal surgery with its risks. Safety and efficacy of diagnostic and the operative hysteroscopic procedures. Thank you. I'm Dr. Ala Musbah, Professor of Obstetrics and Gynecology, Faculty of Medicine, Mansoura University.